refractive surgery. Part 8. Enhancement by laser vision correction. We will go through indications, workup, management, and types, starting with the indications. Residual refractive error, unhappy 20/20 patient, refractive error regression, major corneal irregularities, and reduced vision due to other pathologies. Now, the residual refractive error can result from miscalculation, wrong calibration, or wrong input of refraction, or in case of IOL implantation, it can be due to miscalculation of the IOLs. Now, the residual refractive error is an indication for enhancement whenever it is significant, but the definition of significant differs according to patient's demands and patient's age. For example, plus 0.75 means a lot for a patient at age of 40, while it may be insignificant for a patient of 20. The unhappy 20/20 patient. There are refractive reasons and non-refractive reasons for patients with 20/20 to be unhappy. Starting with the refractive reasons, they include small residual myopia affecting night vision, small residual hyperopia affecting near vision, small residual astigmatism, small corneal irregularities, and changes in native high-order aberrations. Actually, these 5 refractive reasons are indications for enhancement. There are non-refractive reasons which are not indications for enhancement. They include dry eye, which is very common after keratorefractive procedures, presbyopia, which may let the patient be unhappy in spite of his 20/20 distance vision, early cataract, which may be misdiagnosed, low contrast sensitivity, which is a side effect of keratorefractive procedures, and inter-eye disparity. For example, when one eye sees 20/20 and the other one sees 20/15, the patient considers the eye of 20/20 as the bad eye. Refractive error regression. The regression of the refractive error may be due to loss of effect, nuclear cataract, diabetes, and the use of medications such as steroids. Starting with the loss of effect. Now, the biomechanics play a very big role in the regression of the treatment or the loss of effect of the treatment. For example, after myopic treatment, there might be some shrinkage at the edges of the treated zone and bulging in the central zone, causing loss of effect. The same can be said in after hyperopic treatment, which may cause bulging at the periphery and flattening at the center. And we should not forget the filling effect of the epithelium, which reduces the effect of the hyperopic treatment, especially when it is done by PRK. Now, what is the definition of loss of effect? It is a progressive regression of part or all of the pre-op refraction, but not exceeding it, and there must be tomographic changes that are inconsistent with ectasia. We will come later to the tomographic changes that are consistent with ectasia. So the definition of loss of effect is a progressive regression of part or all of the pre-op refraction but not exceeding it. In addition, the tomographic changes are not compatible with ectasia. Now, among these reasons of refractive error regression, the only reason that is an indication for enhancement is the loss of effect. Of course, other causes such as nuclear cataract, diabetes, and medications should be diagnosed and treated accordingly. Major corneal irregularities. They include ectasia, small optical zone, steep or flat optical zone, and decentered optical zone. Now, what is ectasia? Ectasia is a progressive new refractive error, especially new astigmatism. And we have to emphasize on the word new. It is not a regression of part or all the pre-op refractive error. It is a new refractive error, especially new astigmatism. In addition, the tomographic changes indicate ectasia. Now, what are the tomographic changes indicating ectasia? There must be three parameters. The first one is abnormal posterior elevation, where we find high values on best fit sphere and or best fit toric ellipsoid. In addition, we have to find abnormal anterior curvature in group B, C, and D, as we will see now. I classified the patterns on the curvature map into 4 groups. Group A includes the round, oval, and symmetric bow tie patterns. Group B includes the superior steep, asymmetric bow tie superior steep, inferior steep, asymmetric bow tie inferior steep. While Group C includes the symmetric bow tie with skewed radial axis and asymmetric bow tie with skewed radial axis. So Group C includes the skewed patterns, while Group D includes the butterfly, crab claw, vertical D, irregular, and the clone pattern. Now, to say that these patterns are one of the parameters for ectasia definition, it must be either inferior steep or asymmetric bow tie inferior steep, or symmetric bow tie with skewed radial axis or asymmetric bow tie with skewed radial axis, butterfly, crab claw, vertical D, or clone. So these patterns are hallmark for ectasia when they accompany the other parameters. Now the third parameter is abnormal pachymetry, which might be a difference, inferior-superior difference more than 30 microns, and or y-coordinate more than minus 0.5 millimeters. As we see in this example, there is a difference, inferior-superior difference more than 30 microns. In addition, there is a big displacement of the y-coordinate as it is shown here, minus 2.33. So to say it is an ectasia, we have to find tomographic changes indicating ectasia, which are abnormal posterior elevation, abnormal anterior curvature, and abnormal pachymetry. Now, the second major corneal irregularities is the small optical zone. As you see here, this is post-PRK treatment. There is small optical zone. This small optical zone is in the vertical meridian. It is small while it is normal in the oblique or horizontal meridian, as it is shown here. The third major corneal irregularities as an indication for enhancement is steep or flat optical zone. This is an example of steep optical zone, and this is an example of very flat optical zone. As you see here, you can find numbers, 28 diopters, 29 diopters. The cornea is very, very flat. The decentered zone, such in this example. All of these major corneal irregularities are indications for enhancement. The reduced vision due to other pathologies. Sometimes, after the operation, the patient may have reduced vision due to cortical or subcapsular cataract, retinal and optic nerve diseases, or corneal opacities such as haze. Especially when the haze is very mild, it can be misdiagnosed. Conclusion 1. Indications for enhancement are significant residual refractive error, refractive reasons for unhappy 2020 patient, loss of effect, and major corneal irregularities. Coming to the second part of this video, the workup. Now, what we should do before we say we are ready for enhancement. We have to measure incorrect visual acuity, corrected distance visual acuity, potential visual acuity in some cases. We have to measure contrast sensitivity. We have to determine the manifest refraction and cycloplegic refraction. Cycloplegic refraction is mandatory in all cases for enhancement. We have to do corneal tomography and topography. Topography is more important than tomography, especially in cases of irregularities or corneal opacities. We have to do total wavefront if available, or at least corneal wavefront. Careful slit lamp biomicroscopy is very important. We have to do dilated fundus and crystal lens exam. Dry eye workup is very important. We have to do it in every case for enhancement. It includes tear film breakup time, Schirmer test, corneal sensation test, corneal staining, and careful inspection of the lids in order to diagnose the blepharitis, especially meibomian gland dysfunction. Now, within the workup, if we can do a very important test called the Objective Scatter Index, it will be very helpful. It is a device that measures the scatter of light of the crystal lens in order to diagnose and exclude very early cataracts that can be misdiagnosed on the slit lamp biomicroscopy. This will affect the decision for enhancement or even for phakic IOL implantation. This can be done especially in ages above 40s. Now, what is the OSI? The OSI can measure as I said, the scatter of light within the crystal lens, and then it classifies and gives a number to this scatter. When the eye has an OSI less than 1, it is a normal eye. When the OSI is between 1 and 3, it is an early cataract, and so on. Whenever the OSI increases in number, the cataract becomes more mature. Now, as you see here, if we have a patient who is above 40 and we have the facility to do the OSI for him, and we found that his OSI is between 1 and 3, it is an early cataract. So in this case, we will avoid doing enhancement, and we may start thinking of doing cataract extraction with IOL implantation. So the OSI is very important, especially in patients above 40. And finally, it's very important to inspect the general health and to look for any medication that the patient is taking, because many general health conditions may affect diagnosis, treatment plan, and even the results, such as diabetes, hypothyroidism, taking the steroids, and etc. Conclusion 2, we have to inspect dry eye, we have to inspect cataract, we have to do cycloplegic refraction, and it's very important to do wavefront analysis. The third part of this video is the management. There are 5 guidelines for the management. The first one is we have to exclude non-refractive causes. We have to understand patient's demand. We have to give time for adaptation and stability before we proceed for enhancement. We have to determine the indication of enhancement. And finally, we have to choose the proper type for the patient. Starting with the first point, exclude non-refractive causes. We have to exclude and treat dry eye. We have to exclude and treat corneal opacities, cataract, diabetes, medications, retinal and optic nerve diseases. Second, we have to understand patient's demand. First of all, is he an unhappy 20/20 patient? If yes, we have to know why. Does he have presbyopia? Does he have low contrast sensitivity, small refractive error, small corneal irregularities, small changes in native high-order aberrations, or any inter-eye disparity? Or he is an unhappy less than 20/20 patient because he has a significant residual refractive error or a major corneal irregularities, including ectasia, small optical zone, steep and flat optical zone, or decentered zone. Then we have to give time for adaptation and stability. If the patient is unhappy 20/20 patient because of presbyopia, low contrast sensitivity, small refractive error, small corneal irregularities, changes in native high-order aberrations or inter-eye disparity, or when the patient is unhappy less than 20/20 patient because of significant residual refractive error or major corneal irregularities, in these cases, we have to give at least 6 months of adaptation, except for ectasia. Whenever we diagnose ectasia, we have to act. We have to do cross-linking or other modalities of treatments according to the indication, but we should not wait. Otherwise, we have to give at least 6 months in order to give the patient the chance for adaptation, and you will find that a lot of these indications will disappear. Number 4, determine the indication for enhancement. Usually, if we give enough time for the patient to adapt, we will find that the indications are small refractive error, small corneal irregularities, significant residual refractive error, and major corneal irregularities. Finally, we have to choose the proper type for treatment for the patient, and this is conclusion number 3. So conclusion number 3, exclude non-refractive causes, understand patient's demand, give time for adaptation and stability, then determine the indication of enhancement and choose the proper type for the patient. By this, we come to the type of, or the types for enhancement. There are 2 types of enhancement according to the laser profile. There is the optimized laser profile and the customized laser profile. In addition, there are 2 types according to what we are going to do. Either we do laser vision correction after keratorefractive procedures, such as laser after laser vision correction or RK, or we do laser vision correction after lens implantation, either phakic IOL or IOL. So starting with the first 2 types, optimized laser profile versus customized laser profile. Now, if we want to know whether we have to go for optimized laser profile or customized laser profile, we have to do the following workup. First, we have to test vision with glasses in the clinic. Whenever the patient comes to our clinic and we test his incorrect and best correct visual acuity in addition to his manifest refraction, we put the glasses on his eyes and then we ask him, are you happy with these glasses? If the patient can see 6/6 clearly and the tomography and topography do not show any irregularities and the wavefront analysis does not show any significant high-order aberrations, in this case, we have to go for optimized. While if the vision with the glasses is not optimum, the patient can see 6/6 unclearly or less than 6/6, or he is not happy with this vision, and the topography and tomography show irregularities and the wavefront analysis shows significant high-order aberrations, in this case, we have to do the customized laser treatment. We have to be sure that we have to use the customized or the optimized. Otherwise, if we do the customized for optimized cases, then we may induce high-order aberrations and we may cause additional and more unhappy 20/20 patients. Coming to the other two types, according to what we are going to do. Are we going to do laser vision correction after previous keratorefractive procedures, or we are going to correct any residual refractive error or induced refractive error after lens implantation? Starting with the first one. There are several types of this type, or let us say there are several subtypes of this type. PRK over PRK, PRK over LASIK flap, new cut after LASIK flap, relift the LASIK flap, PRK after radial keratotomy, and LASIK after radial keratotomy. The other type, which is laser vision after lens implantation, has two subtypes. The first one is PRK and LASIK. So we either do PRK after lens implantation or we do LASIK after lens implantation. However, there are precautions. If we do laser vision correction after previous keratorefractive procedures, there are two major complications, haze and epithelial ingrowth. And if we do laser vision correction after lens implantation, there are two major complications, which are the toric effect and the decentered ablation and its bad effect on this type of treatment. Starting with the PRK over PRK. What are the rules when we do PRK over PRK? We have to calculate the post-op thickness, including the epithelium. It should be more than 400 microns. In addition, the post-op K should be between 34 and 49 diopters. The post-op Q value should be between 0 and -1 because we don't want to induce oblate cornea or hyperprolate cornea. And we have to follow the preventive measures of haze. Now, what are the preventive measures of haze? There are 7 preventive measures of haze. We have to avoid small optical zone, less than 6 mm. We have to apply mitomycin C. We have to use vitamin C for at least 6 weeks. The patient should use sunglasses for at least 1 year. In addition, we have to enhance epithelium healing. And the patient should use lubricants for at least 3 months. And steroids should be used for at least 3 months. Of course, weak steroids to avoid side effects such as cataract and increased the IOP. The other subtype is PRK over LASIK flap. The guidelines for doing PRK over LASIK flap are the post-op K reading should be between 34 and 49 diopters. The post-op Q value should be between 0 and -1. The flap thickness should be sufficient in order to apply the ablation depth. And do not remove the epithelium mechanically and follow the preventive measures of haze. Starting with the sufficient flap thickness. When we apply PRK over LASIK flap, we have to be sure that there will be a residual stroma of the flap after the operation. Otherwise, if we ablate the whole thickness of the flap, we will end up with scarring or corneal irregularities. For example, if the flap thickness was 130, the flap stroma is supposed to be 80 microns, and if the ablation depth is around 80 microns, so we cannot do the treatment. This is another example. The flap thickness is 150, and the stroma of the flap is supposed to be 100. And if the ablation depth is 50 microns, so we can proceed with the treatment. Do not remove the epithelium mechanically. You have to remove the epithelium either by alcohol 20%, PTK, or trans PRK. And finally, we have to follow the preventive measures of Hayes. So, when we want to do PRK over LASIK flap, we have to pay attention to post-op K readings. We have to pay attention to post-op Q value. We have to calculate the flap thickness properly, and we should not remove the epithelium mechanically, and we should follow the preventive measures of Hayes. What about the new cut? The new cut is not preferable because there are a lot of disadvantages. We may open the previous flap. We may end up with irregular flap. If we do a new cut in the stroma, maybe we will initiate ectasia process in addition to epithelial ingrowth. Relifting the flap. The disadvantages of relifting the flap are epithelial ingrowth, dry eye, and ectasia. But if we want to do relift the flap, we must have full information about the previous flap, and we have to follow the preventive measures of epithelial ingrowth. First, you must have full information. We have to know if we have sufficient bed area, diameter, especially if we are going to do customized laser treatment, because it may ablate a large optical zone. We have to calculate the PTA, and it should be less than 40%. The post-op Q value and the post-op K readings should be considered as well. In addition, we have to follow the preventive measures of epithelial ingrowth. What are the preventive measures of epithelial ingrowth? We have to avoid relifting the flap in epithelial basement membrane dystrophy, new vascularization, especially across the flap edge, history of ingrowth either in this eye or the other eye. If I had done a previous myopic LASIK, difficulty in follow-up the patient. We have to know that the incidence of epithelial ingrowth is 1% within the first 3 years after LASIK, previous LASIK treatment, and it increases to 7% when we do the relift of the flap after 3 years of the previous LASIK treatment. The other subtype is PRK after RK. It is not recommended due to refractive instability. However, if we want to do it, we have to follow the preventive measures of Hayes. And finally, if we want to do LASIK after RK, it is not recommended due to refractive instability and due to flap complications. Now we come to laser vision correction after lens implantation, either phakic IOL or IOL. Now we can classify this into A, B, C. If the previous lens implanted in the eye was monofocal, if it is multifocal or trifocal, or toric. Monofocal, when the previous lens is monofocal. We have to exclude decentration of the lens before thinking of enhancement. We have to exclude posterior capsule opacification in case of previous cataract and IOL implantation. And if it is a case of phakic IOL and refractive error after the implantation of the phakic IOL, we have to exclude cataract in the crystal lens. We have to target the refraction, and then we have to decide whether to go for conventional or customized laser treatment. Starting with the exclusion of decentration, we have to do dilated exam. We have to suspect the decentration when we see disparity between tomography and total wavefront analysis. Targeting the refraction, we have to measure the manifest refraction. We have to give the patient a trial contact lens and let him come to us in multi-visits in order to adjust the power that the patient is happy with, and then let the patient share us in the decision what is the power that he is okay with. And after that, we will decide whether to go for the conventional or customized laser treatment by measuring the manifest refraction and measuring the high order aberrations. This is for the monofocal lenses. But if the lens inside the eye is multifocal or trifocal and the patient has refractive error and we want to do enhancement, what should we do? First, we have to exclude decentration. We have to exclude posterior capsule opacification if there was a cataract extraction and IOL implantation. We have to explain to the patient the quality of vision. We have to target the refraction, and we have to plan for conventional or customized laser treatment. Now, how to target the refraction in multifocal or trifocal lenses? By measuring the manifest refraction and giving the patient trial contact lenses with multi-visits and let the patient share us in the decision. But in general, if the lens that was implanted was restored, we have to target plano in both eyes. If it was thickness, we have to target plano in dominant eye and plus 0.5 in the non-dominant eye. If it was crystal lens, then we have to target plus 0.25 in the dominant eye and minus 0.5 in the non-dominant eye. Coming to the toric lens. If the eye has a toric lens and we have the eye has a refractive error and we want to do enhancement, what should we do? We have to exclude decentration, of course. We have to exclude posterior capsule opacification if it is an IOL, and we have to exclude cataract if it is a phakic IOL. We have to determine the type of refractive error and determine the amount and axis of the manifest astigmatism. How to exclude decentration? By dilated exam, and when we see a disparity between tomography and total wavefront analysis. We have to determine the type of refractive error and axis of manifest astigmatism. If the patient has, if we compare the previous astigmatism and refractive error with the recent astigmatism and refractive error. If the patient has new astigmatism with new axis, then we have to rotate the lens. If the patient has new astigmatism with the same pre-op axis, then we have to do enhancement. And if the patient has only sphere, then we have to do enhancement. So we do enhancement if the patient has residual refractive error of only sphere or new astigmatism but with the same pre-op axis. Otherwise, if it is a new axis, then we have to rotate the lens. We can go for LASIK and we can go for PRK in such cases, but the disadvantages of LASIK are flap complications and dry eye in the old age, while the disadvantages of the PRK are the delayed healing in the old age and the infection in the old age. So, conclusion number 4, optimized treatment is the rule. Customized treatment is done only if the corrected visual acuity is suboptimum due to high-order aberrations and corneal irregularities. Relift the flap during the first 3 years if you have full information and accurate measurements. Otherwise, do PRK. Number 4, calculate post-op K thickness and Q as inversion eyes. And finally, rule out decentration or rotated lenses. Thank you very much.